Assalamu alaikum. Our topic in this presentation is about one of the most common and serious orthopedic infections, septic arthritis. Again, for all my lectures and presentations, this is just a concise presentation, and for more information, you need to go back to your textbook, Apley's and Solomon's Systems of Orthopedics, and you can review it on orthobullet.com as well. So septic arthritis is a pyogenic infection of the joint that causes inflammation in that joint. Usually it peaks up in the first few years of life. The incidence for septic arthritis is about 4 to 5 per 100,000 children annually. 50% of septic arthritis happens in the first 2 years of life, and it's more common in males in comparison to females with a 2-to-1 ratio. It can happen at all synovial joints. During infancy, hip is the most common joint to be affected. About 35% of septic arthritis happens in the hip joint. In adulthood, knee is the most common joint with septic arthritis. 50% of septic arthritis in the adults happens in the knee joint. Sacroiliac joint and sternoclavicular joint are the most common affected in IV drug abusers. Regarding the etiology of septic arthritis, infection usually spreads to the joint either through a hematogenous route, through the blood, in which 80% preceded by an upper respiratory tract infection, bacterial infection. It can spread to the joint through an exogenous route from the outside, and that involves skin penetration, either by trauma or injection or surgery. A contiguous spread of surrounding infection to the joint, especially osteomyelitis, which involves the metaphyses of some joints, that can spread to the joint itself and causing septic arthritis. Now, the infection of osteomyelitis to spread into the joint and cause a septic arthritis, it can go through two routes, either directly, like in the yellow arrow, crossing the physis, the growth plate, to the epiphysis and to the joint, and that only can happen during infancy, in which there's a transfesial blood vessels crossing the physis, and that can cause becomes like a bridge for the spread of infection from the metaphysis to the joint, or if the metaphysis is an intracapsular structure. So a horizontal spread of osteomyelitis can go toward the cortex and enters the joint as the metaphysis is intracapsular. In which joints of the body the metaphysis is an intracapsular structure? Most of the large joints except for the knee. So it can happen in the hip, shoulder, ankle, and elbow. So why do we consider septic arthritis an orthopedic emergency that has to be treated as soon as possible? Because the consequence of not treating a septic arthritis is catastrophic. The infection can cause a destruction to the joint, destruction to the cartilage, that ends up with ankylosis and losing the joint. The damage of the cartilage involving the joint, and the involved joint, can happen directly from the bacterial effect. The bacteria that causes the infection septic arthritis inside the joint can forms a biofilm that attaches itself to the cartilage, so it's not easy to get rid of the infection and bacteria from the cartilage if not treated promptly, as well as it will release a lot of virulent factors, including exotoxins, enzymes that causes a direct damage to the cartilage. On the other hand, the inflammatory response, the body inflammatory response by the effect of releasing of cytokines, macrophages, neutrophils, all of these will cause a release of a lot of enzymes, lysosomal enzymes, as well as the host matrix metalloproteases. The matrix metalloprotease as well as the lysosomal enzymes can cause a direct damage to the cartilage. This can happen as quick as 8 hours. So you have to treat septic arthritis as soon as possible, or you will end up with a cartilage damage. The inflammatory response and the increase of the amount of fluid inside the joint can cause a drastic increase in the intra-articular pressure. This will cause a compression on the surrounding blood vessels and can cause osteonecrosis to the cartilage and bone in that joint. A patient with septic arthritis usually presents with acute severe pain associated with a lot of systemic symptoms. The patient will look ill, unable to walk, refuses to be weight on that joint, presented with high-grade fever. When you look at the joint will be swollen, tender, it can be warm. The patient usually will hold the joint and the limb in a certain position that allows and maximize the volume, the intracapsular volume of the joint, so it can hold that amount of effusion and inflammatory process secretions. For the hip joint, the position that the patient prefers usually is flexion, abduction, and external rotation, as you can see in the right image on the top. For the knee joint, usually it is held in a little bit of flexion, 30 to 45 degrees of flexion. If you try to move the joint, it will be very painful for the patient. The patient will not allow you even to do a log rolling for the hip. And even the patient will hold the joint in certain position and refuse to move it, and that's what we call a pseudoparabolic. The diagnosis of septic arthritis usually depends on clinical suspicion, as you don't have a lot of time and the luxury to do a lot of imaging modalities to reach your diagnosis. As we said previously, damage to the cartilage and joint itself can happen as early as 8 hours after the onset of infection. But what imaging modalities to order and what to expect in each modality. Now in conventional x-rays, radiographs, usually you have to order 2 views for any joint that you do an x-ray for. For the hip joint per se, we order usually an AP and the frog leg lateral x-ray. The early findings of septic arthritis, usually if you do an x-ray, in the early period after the onset of infection, it's normal. You can't find anything. But after the collection of effusion and the fluids inside the joint, you can start noticing widening of the joint space. Now, if you look at the X-ray on the right, look at the left hip. That's the normal joint space for the hip joint at this age. If you look at the right hip, you can notice a widening of the joint space. That's due to the collection of fluid and the effusion that comes with septic arthritis. Before the appearance of this ossific nucleus that you can see on this X-ray, the only thing that you can notice is a lateral displacement of the femur itself, of the femur shaft, due to the effusion and collection of fluid. It might present as a subluxation of the joint or even a dislocation as it appears on the right side of this joint, of the hip joint. If left untreated, we said the consequence of that is catastrophic. It can lead to avascular necrosis and full destruction of the joint itself, of the joint cartilage, and due to decrease in the blood supply to the head of the femur, as in this X-ray, this will lead to osteonecrosis of the head. Ultrasound can help us in two things. First, to detect the amount of effusion and fluid inside the joint, and this might help us with aspiration, ultrasound-guided aspiration. Now, if you look at the image at the right side, you can have H standing for the femoral head, and the JC is the joint capsule. You can see the very minimal amount of fluid and collection in a normal hip. If you compare it to the left image, you can see a lot of fluid collection around the femoral neck and the femoral head, and this indicates septic arthritis. MRI can be used in equivocal cases that you can't reach a diagnosis in a partially treated patients, and you can see collection around the joint itself, widening of the joint space as well. For the blood tests, we usually order a complete blood count with inflammatory markers. In the complete blood count, we look at the white cell count. As all infections, it will lead to an increase in the count of the white cells, with a left side shift increasing the number of neutrophils as it is a bacterial infection. It is worth noticing that in neonate, septic arthritis may present with leukopenia. For inflammatory markers, we look at the ESR, the erythrocyte sedimentation rate, and it is considered positive if it's more than 30 millimeters per hour. Another inflammatory marker is the CRP, the C-reactive protein. With a value of more than 3 milligram per deciliter, this can yield a 74% probability of having a septic arthritis. The good thing about the CRP, it rises very fast, so you can use it for detection of infection as early as possible. And once you normalize the infection, it goes back toward normal quickly. So you can use it as well to monitor the response of treatment. For the value of the CRP to be considered as a high risk for diagnosing septic arthritis, it should be more than 3 milligrams per deciliter. The normal value of a CRP is less than 1. A 1 to 2 will give us a desirable risk for having septic arthritis, and more than 2 is moderate risk to have septic arthritis. Now, for the clinical features and the lab tests that we talked about in septic arthritis up till this moment, the sensitivity of these findings to diagnose septic arthritis is fever having the higher sensitivity, C-reactive protein is the next, ESR, then refusal to be weighed, and increase in the white cell count. So increase in the white cell count per se by itself have a low sensitivity for the diagnosis of septic arthritis. We have a very helpful diagnostic tool for the diagnosis of septic arthritis called the Kocher criteria. The original Kocher criteria, it includes 4 criteria. These are fever more than 38.5 degrees Celsius, ESR more than 40, inability to be weighed, and the refusal of the patient to stand on that limb. And the 4th criteria is a white cell count of more than 12,000 cells per microliter. Now, as you see, the number of features, if the number of these features increase, the probability of having septic arthritis will increase. So if you have only 1 criteria of these Kocher criteria, the probability of having septic arthritis is 3%. But if you have all 4, the probability will increase up to 99.6%. Now, what is the cut point to diagnose septic arthritis? Now, if you look at the number 2, if we have only 2 criteria of Kocher criteria, the probability of having a septic arthritis is considered around 40%. Now, for a patient with septic arthritis, as we said, the consequences of untreated septic arthritis is catastrophic. 40% is considered very high. So, if you have fever more than 38.5, and the patient is refusing to be weighed on that joint, that gives you a probability of 40% to having septic arthritis. And that's why we say that the diagnosis of septic arthritis should rely on your clinical suspicion. Now, should I go for joint aspiration for the diagnosis of septic arthritis? If it's a clear picture, a full-blown picture of an inflamed, infected joint, you don't go for aspiration. You go right away for the management step that includes cleaning of the joint with surgical debridement. Once you do your surgery, you collect the fluid and you send it for culture and sensitivity. Now, if it's not that clear, you go for aspiration. Aspiration will help us to diagnose the infection. You can send it for gram stain and culture. And after aspiration, if the aspirate gives you a highly suspicion of having a septic arthritis, you go for surgery right away. And you start your antibiotic, your empirical antibiotic treatment, as soon as you finish your aspiration, because you collected the fluid to send it for culture and sensitivity, and now you can start your antibiotic treatment. How to do it? You have to use a wide bore needle. This can be done manually or under guidance of imaging using ultrasound, CT scan, or fluoroscopy. What to expect to find in these aspirate in septic arthritis in comparison to other conditions, other non-inflammatory and aseptic inflammatory conditions. The amount of synovial fluid present inside any joint is very minimal. With infusion due to inflammatory and non-inflammatory condition, this amount can increase and you can do aspiration of it. The normal color of synovial fluid is clear. If there's an inflammation, it will become more yellow. If there's an infection, it can become turbid. The viscosity of the synovial fluid is very high. And there's a viscosity test by putting it between your fingers and try to spread the fingers to see if there's a bridge forms between your fingers once you spread them. With inflammation and infection, the viscosity of this fluid will decrease. The amount of white cell count in a synovial fluid is very minimal. It's less than 200. To diagnose a septic arthritis, you should have more than 50,000 cells per cubic millimeters of the synovial fluid aspirate. Neutrophils with infection, it's a bacterial infection, the neutrophils should be very high. To diagnose it as a septic arthritis, it should be more than 75% of your cell count. And then you send it for gram stain and culture. For sure, infection will yield a positive gram stain and a positive culture. If you check for glucose, you have to compare it to plasma level of glucose. The normal synovial fluid, usually the amount of glucose level in it is equal to the amount of glucose present in the plasma. In septic arthritis, the amount of glucose will decrease. It becomes less than 25 milligram per deciliter, less than what present in the plasma. What is the management of septic arthritis? It's surgery. It's a surgical emergency. You have to do surgery and clean the joint as soon as possible, within 8 hours of the onset of infection, to minimize the risk of having joint destruction and cartilage destruction. It can be done arthroscopic or arthrotomy, open surgery, to clean all the fluid, to collect the fluid. If you didn't do a joint aspiration, send it for culture and sensitivity. You can take synovial cultures and irrigate with a lot of normal saline to clean the joint. Once you've done your cleaning, you leave a drain in to relieve any collection that might happen after closing the wounds. You've done your surgical management. When to start your antibiotic treatment? We said if you go for aspiration, you should start your empirical antibiotic treatment as soon as you get your aspirate. If you're going for surgery right away, you collect the fluid, and while you're doing your cleaning, you ask the anesthetist to start giving the proper empirical antibiotic. Once you get your culture result, you switch to the antibiotic targeted to your pathogen. The duration of treatment using antibiotic should be a minimum of 4 weeks. At least 1 week of this duration should be IV antibiotic. And once you start monitoring the response for antibiotic treatment, if your clinical features, lab test, the ESR and CRP started to decrease, after 1 week, you can switch to oral antibiotic and continue for another 3 weeks. What empirical antibiotic you should start your patient on until you get your culture results? So as we said, infection, septic arthritis, osteomyelitis is age dependent. In the first year of life, especially in the first 3 months, you expect group B strep to be the most common microorganism. As long as you have that in mind, you should give antibiotic that covers the gram-positive bacteria. So you can start your patient on first generation cephalosporin. And even you can use a penicillin, an ampicillin, or an amoxicillin for this treatment. After the 3 months of age, the Staph aureus becomes the most common microorganism, but you might have a gram-negative microorganism. You can have a group A strep infection. You can have a Haemophilus influenza infection if the patient did not receive vaccination. Haemophilus influenza used to be one of the most common microorganisms that causes septic arthritis and orthopedic infections in general, but it decreases dramatically after the introduction of Haemophilus influenza vaccine. So at this age group, you should cover gram-positive and gram-negative bacteria. So you can start your patient on a second or third generation cephalosporin. After the 5 years of age, Staph aureus is the most common microorganism. Staph aureus is a gram-positive. Start on first generation cephalosporin. In communities where there is a high prevalence of methicillin-resistant Staph aureus, you can start your treatment with vancomycin. In adolescents, Staph aureus again is the most common microorganism, but there is a probability of having a Neisseria gonorrhea. So you start your empirical antibiotic treatment to cover these 2 microorganisms. A second or a third generation cephalosporin will be good enough to cover both.